I was going to talk a little bit about, sort of my perspective of where we were when I started, in cancer care as a fellow and as a junior faculty member approximately 40 years ago. And I'm just going to highlight a little bit breast cancer and lung cancer. Many of you probably don't remember or even think about where we might have been, but the difference is so striking and so relevant. And just think about how fast we're moving now compared to what I'm describing. So breast cancer, when I was a fellow, Johns Hopkins Oncology Center and the NCI, where I did my training in both institutions, you had a patient with breast cancer. Obviously, first therapy was surgery, then went to radiation, then maybe you gave adjuvant chemotherapy. And if a patient developed metastatic disease, you gave chemotherapy and maybe hormone therapy, and that was it. I mean, I cannot emphasize how simple the paradigm was. Now, for patients, this was not necessarily a good situation, but that's where we were. So if a patient was ER positive, PR positive, we give them hormonal therapy. That could have been a surgical manipulation, or it could have been tamoxifen at that point in time. And that's what we had. We did give adjuvant chemotherapy, so that could have been a CMF or an adriamycin-based regimen. Again, that was it. In the metastatic setting, we had the same drugs. Very little focus on the questions of quality of life. Obviously, toxicity was an issue. Those are immediate concerns, nausea and vomiting, lowering the blood counts. This was obviously before the days of growth factors. But you can monitor the blood counts. There was no such thing as molecular class stratification of the disease. We did not use combination therapies. Things were sequential, certainly when it came to the question of hormonal therapy and chemotherapy. There were very limited second line options. You might try it, but you knew it didn't work very well. Or a patient could go on a clinical trial and that wasn't of that much value. There was no such thing as neoadjuvant chemotherapy. The idea that you'd give chemotherapy first, followed by surgery, didn't happen. There was no such thing as tumor agnostic drugs. And very importantly, the length of survival was relatively short, and the concept of thinking of this illness as a more of a chronic illness would not have crossed anybody's attention. It was metastatic disease. You have hormone therapy, you might give chemotherapy, short period of time, and that was it. Adjuvant therapy, you give adjuvant therapy, and then you were done. Turn a moment to lung cancer. That was even simpler, but obviously much worse for those patients. We divided patients into small cell lung cancer and in non-small cell lung cancer, which again, we obviously still do today. But the issue there was, why did you care if it was small cell lung cancer? Well, you wouldn't operate, you'd give chemotherapy because the patients all had metastatic disease, so surgery was not an option. And non-small cell lung cancer, chemotherapy didn't work very well. So in a small percentage of patients, you might operate, you might give radiation, and then you potentially give chemotherapy for a very short period of time. That's all you had to know. Chemotherapy was very ineffective, a little more effective in small cell lung cancer, get a high response rate lasting for a number of months. And then palliative care was the option. You literally knew about non-small cell lung cancer and didn't worry about anything other than the fact that it wasn't small cell. That was the management paradigm. Certainly no such thing as adjuvant chemotherapy that was of any value. That's where we were. There was no such thing as molecular classifications, no such thing as liquid tumor biopsies, and that was the management. Point being here is that if you were a clinical oncologist in that era, you could take care of lung cancer, you could take care of breast cancer. By the way, you had the same chemotherapy drugs, which were limited. You had to know how to use hormonal therapy, but that was the management. So I'm going to stop there in this segment, and just to emphasize for those of you who hadn't appreciated, that was the management of two of the most common cancers as recently as 40 years ago. Decision support wasn't really that critical, and that's where we were. The next segment, I'm just going to talk a few minutes about how dramatically things have changed in those two diseases, just those two diseases. I thank you for your attention.